Hi everyone, my name is Ryan Hay. Today we're going to discuss tuberculosis in the homeless adult population. We're going to discuss the homeless adult population as a whole, looking at some statistics, what defines that population, and specifically kind of drilling down to tuberculosis itself, its treatment pathways, why it's a medical diagnosis that tends to be prevalent in homeless adults, as well as the different primary, secondary, and tertiary interventions that the advanced public health nurse can take in helping to manage TB in this population. So looking at a background of the population itself, we have some information from HUD, the Department of Housing and Urban Development, that shows that just over about 500,000 homeless on one single night in January 2016. So what they did was they took a whole study and they looked at what the homeless population was across the country in all the states on one given night, just to try to get a snapshot view of that. 22% or so of those individuals were children. The remainder were all adults, obviously. About 68% were sheltered, so they were whether in a temporary shelter, some sort of emergency shelter, or permanent homeless shelter of some nature. The remainder were actually just basically on the streets or without shelter that evening. What's interesting is that there was about 800,000 beds available nationwide on the same night, and more than half of those are permanent homeless beds. So there was a significant number of beds available. However, the numbers obviously don't quite match up where those beds are, where the homeless populations are, and there's a little bit of a mismatch there. What's interesting is that with these permanent beds for the homeless, we'll talk a little bit about how sheltering and the environment that they're kept in, or that the homeless are staying in while they're in a shelter, might actually end up contributing a little bit to their risk factor for tuberculosis. So background of tuberculosis is a respiratory disease caused by the spread of M. tuberculosis. Is a droplet. Precautions is what nursing takes. And it's from human to human transactions. So cough, sneeze, airborne droplets kind of get transferred from one to the other. Many have heard latent versus active TB. Basically, the difference is active TB, you're actively symptomatic. It's infecting you, it's causing an infection, whereas latent is you have kind of the presence of the bacteria without necessarily any sort of directly associated symptoms at the time. About a quarter of the world's population either has latent TB or active TB, but TB of some sort, according to some CDC data that we saw. So really, this is a very prevalent bacteria among our population as a whole, and obviously kind of putting the homeless at a little bit of a higher risk. So diagnosis of tuberculosis managed through a physician or an advanced practice nurse. Fever, sweats, and weight loss are kind of the initial starting symptoms, and that can be anything. That can be a wide variety of different disease pathways or disease processes. So we kind of drill it down. As those progress, you start to get cough, chest pain, hemoptysis. Those respiratory symptoms start to develop. Sometimes by the time that happens, you're already kind of infected, symptomatic, and kind of well on your way to buying yourself an admission in the ED or in the hospital from the ED. So our goal is to try to identify this as early as possible in these populations. Skin testing, TST testing, is probably the most common that everyone's familiar with. It does have a risk of running false positives. Some people know that they automatically, every time I take it, I don't have TB, but I get a false positive on it, so they have to get chest x-ray to confirm. Sputum smear is very similar, not definitive, a lot of cross-sensitivity. So really we look at the blood test, the quantiferon gold, and the chest x-ray, and looking for the presence of lesions in that area of the respiratory system to confirm if you have TB or not. So homeless have 3 times the emergency department diagnostic rate of TB rather than non-homeless. And this information came from a study that was actually performed in 2017, published just this month or last month in 2018. And really what it showed is that there's about a 0.3% incidence of diagnosis of TB in non-homeless through the emergency department versus about a 1% among homeless population. So really there's 3 times the chance that a homeless person is going to come in with potential for TB. They also have about 10 times the comorbidity rate than non-homeless with tuberculosis. So they have a lot of other potential medical problems that really factor into this. They have greater non-compliance rate with medication, which we'll talk about, higher instances of ICU admission because of those comorbidities that are causing some complex medical processes, and it's higher instance as a population of tobacco and alcohol abuse, and use of alcohol while taking medication for tuberculosis tends to decrease the effectiveness, which then would link to further disease progression, failure of medication, and continued problems. So we estimate that 1% of the U.S. population as a whole suffers from homelessness, and of that population, 5% of homeless report having TB. So it's a pretty significant number. We talked about some immunosuppression from comorbidities, increased sexual activity, sexual promiscuity tends to lead to the potential for an increased risk of HIV, AIDS, sexually transmitted diseases that are immunosuppressive, as well as bloodborne pathogen or bloodborne infectious diseases that could potentially suppress the immune system and its ability to fight off tuberculosis if and when they're exposed. Medical compliance is also an issue, specifically dealing with medication regimens. And of course, treatment follow-up compliance kind of rolls into that simply because they're homeless. They don't necessarily have a primary care provider. They don't have means to travel, potentially. They may not have means to pay. So there's a lot of barriers with them getting the follow-up care they need. So TB treatment, drug therapy is generally 6 to 9 months in duration. It's an intense 2 months followed by a continuous 4 to 7 months. So we're looking at a pretty significant period of time where they have to take medications that are very structured in nature from an administrative perspective. And it's very complex coordination of care during this time. And if we don't have the ability to get them that care they need as efficiently as possible, they have a higher instance or a higher potential to not follow through with the care completely and then end up having increased worsening of symptoms and negative outcomes. Listed a couple of the drugs there. There's 10 FDA-approved drugs for tuberculosis treatment. Those are some of the top kind of 4 that you see a lot that are used. So primary prevention for TB, it's kind of limited options in the U.S. from a vaccination perspective. BCG is not generally recommended for use, and some studies have shown it to be not effective in the adult populations from a vaccination perspective. So we really look at the prevention of the transmission in general. Looking at environmental controls, this is where we go back to the shelters. Can we keep them as clean as possible? Can we try to segregate patients who may be sick versus not sick, or symptomatic versus non-symptomatic? Can we just promote general hygiene there? Getting education for the staff who work there, education for the homeless patients who were there on good personal hygiene, making sure there's soap, making sure there's alcohol, hand sanitizer, warm water, that they can continuously follow through with these hygiene habits to promote a healthy culture. Secondary prevention really focuses on those screening tools. Annually performed snapshot surveillance is a great option for looking at a kind of a large group of individuals, a defined population. You pick out the shelter, soup kitchens, free clinics, areas where you know that the homeless tend to be, and then kind of every year you look at that area compared to the year before or the previous years and determine what the threshold of tuberculosis instances are in that population, if you're trending upward, trending downward, etc. So through that, we kind of have a couple different methods of screening for TB. We can use the skin test, which we've talked about being logistically simple. A nurse is able to administer it and read it. However, it lacks some specificity. You might need some follow-up testing. It's not definitive as a yes or a no. The sputum testing, again, very logistically simple. Just grab a sputum sample. However, 50% with who have TB can potentially have a negative test. So it's not terribly specific to TB, and could kind of cause some confusion there as well. So we look at chest radiography. Chest x-rays as the logistically more complex but most specific. And it's really easily accomplishable if you can define your community, pre-plan ahead of time, get the resources and the funding for the resources out to the sites to get the individuals treated as best as possible and screened as best as possible. Once you've identified that they have either latent or active TB, immediately getting them enrolled into a screening process, or through the screening process and into a treatment process, is critical. We have some data there that shows really that increase in treatment just of a small number of people over the long term will decrease total instances of diagnoses for the same population, which is promising. Tertiary prevention, we focus on direct observation therapy, essentially trading treatment for a desired good or service. So, we enroll them in a program that either gives them housing, gives them food, gives them some sort of transport or some sort of service they need, and in return we make sure that they're complying directly as we observe them with their treatment to ensure that they can have that aggressive treatment therapy, get the drug therapy, treat their comorbidities, and treat it as best as possible so they can have the best outcome and we can prevent the spread. Some data here on secondary and tertiary effectiveness. Basically a 1999 study in Oregon on a pretty significant group of individuals with TB that were homeless showed that there's a really significant drop in active TB rates among homeless over 10 years if they went through this DOT therapy. Finally, a group we don't necessarily always talk about, homeless shelter staff, not typically defined as healthcare workers, but again, they're in the same environment, so they have a similar risk for exposure to TB as the homeless would. So another consideration during screening and surveillance is tying them in with the homeless. So that's about all I have. TB remains an active concern in the homeless population. Prevention requires aggressive outreach, education, and community-centered surveillance. And successive treatment is really contingent on leveraging those resources to screen and promote the completion of the complex drug treatment therapies and comorbidity treatment. And there are my references. Thanks.